Hi, my name is Pamela Coons, Associate Professor of Medicine in the Division of Oncology at Yale School of Medicine and Yale Cancer Center. I'm excited to announce ASCO's new open access journal, JCO Oncology Advances. As the inaugural editor-in-chief, I hope to support JCO Oncology Advances to become the premier platform to bridge the gap between accessible scientific research and clinical care. Stay tuned for more information, including new article types, at ascopubs.org/JCO Oncology Advances. We look forward to seeing your submissions in spring of 2024.
This JCO podcast provides observations and commentary on the JCO article, Adjuvant tamoxifen reduces subsequent breast cancer in women with estrogen receptor positive DCIS, a study based on NSABP protocol B-24 by D. Craig Allred et al. My name is Michael Baum. I am Professor Emeritus of Surgery at University College London and specialize in the research, diagnosis, and treatment of breast cancer. This podcast describes the results from a subgroup of 732 women in the NSABP B-24 trial for the treatment of DCIS, where ER status was available, and describes how this can be used as a predictive test for response to adjuvant tamoxifen. The NSABP protocol B-17 demonstrated the value of adding radiotherapy to surgical excision alone in the management of DCIS when the unacceptably high local ipsilateral recurrence rate was reduced from about 22% to 13% following the addition of postoperative radiotherapy. This was followed by NSABP trial B-24 that investigated the value of adjuvant tamoxifen amongst women receiving post-operative radiotherapy after the diagnosis and surgical excision of DCIS. The addition of tamoxifen was associated with a 37% relative risk reduction in both ipsilateral recurrence and new contralateral disease. In absolute terms, adding about 5% additional benefit in the prevention of local disease. This new paper now looks at the role of estrogen receptor and progesterone receptors as possible predictive factors in selecting patients for adjuvant tamoxifen. In the original B-24 study, there were 1,804 patients randomized between tamoxifen and placebo. This study now looks at the subgroup of 732 women where estrogen receptor status of the in situ disease was readily available. The measurement of estrogen receptor was based on the Allred score, and it was quite fitting to see that Craig Allred was the first author. This is a very mature study with a median time of follow-up of 14.5 years. Primary analysis was time to first event, but I wish to concentrate on the secondary analyses of ipsilateral recurrence or new contralateral primaries. The headline result is clear in that only the estrogen receptor positive group seem to benefit from adjuvant tamoxifen, where the hazard ratio for tamoxifen over placebo was 0.58 for ipsilateral recurrence and 0.50 for contralateral disease, lumping together invasive and in situ phenotypes. Now, although no statistically significant effect was seen in the ER-negative group, they only comprise about 25% of the total sample. I'm happy to accept these findings for ipsilateral recurrence amongst ER-negative cases, where the hazard ratio was 1.18, with confidence intervals of 0.6 to 2.34. But I can't accept the result for contralateral disease, where the hazard ratio was 0.46 favoring tamoxifen, with confidence intervals of 0.12 to 1.80. It makes no sense to me why the ER status of the primary disease should impact on the potential of tamoxifen in preventing new ER-positive disease in the other breast. I think this is a common problem when dealing with small numbers in subgroups in clinical trials, as the statistical power of the beta error drains away. There are only 10 contralateral events in the estrogen receptor negative group overall, and that provides insufficient numbers for any type of conclusion. One last point. The increasing rate of detection of DCIS is the penalty we pay for screening. And in fact, 80% of the cases in this study are screen detected. As the increasing incidence of DCIS has not been accompanied by a fall in the incidence of invasive cancer, then many of these cases have to be considered as overdiagnosed. If that is the case, then maybe instead of looking for cases with DCIS that might or might not respond to tamoxifen, we should be looking for cases using histological and molecular variables that might allow us to decide whether or not to offer any treatment in the first place. The ER status doesn't seem to fit that bill, as the overall recurrence-free survival is very similar, 26% and 30% respectively, at 14 years for the placebo control in the ER-negative and ER-positive groups. This concludes this JCO podcast. Thank you for listening.
For more original research, editorials, and review articles, please visit us online at jco.org. This production is copyrighted to the American Society of Clinical Oncology. Thank you for listening.